All right, looks like we're getting a quorum. Maybe we should go ahead and get started. So good afternoon, everyone. I'm Dr. Miriam Kamarami, the medical director of the Grayken Center for Addiction at Boston Medical Center, and I'm a professor at Boston University. We hold monthly or more often talks by folks in the addiction medicine and addiction prevention fields. And we're holding a special session today to introduce Dr. Stefan Kertész, who's going to speak with us about his study that he's leading on suicides after prescription opioids are reduced. It's really a pleasure to have Dr. Kertész speaking with us today. He is an investigator and physician at the Birmingham VA healthcare system and a professor of medicine at the School of Medicine at the University of Alabama at Birmingham. And Dr. Kertész has a pedigree here in Boston, starting his career as a full-time physician at Boston Healthcare for the Homeless in 1996, and then was at the BU School of Medicine as clinical faculty and a fellow in general internal medicine from 2000 to 2002. As I mentioned, Dr. Kertész is leading this VA-funded study called The Clinical Context of Suicide Following Opioid Transitions, or CSI Opioids. And he is here to describe the background, the literature and evidence related to suicides following reduction in opioid prescribing, and to tell us about his study. So take it away, Dr. Kertész. We're so happy to have you with us.
Thank you so much, Miriam. It really is gratifying and emotionally meaningful to me to speak to a Boston Medical Center and BU audience because of where I started my career with help from people like Jim O'Connell and Jeffrey Samet, Rich Sates, Dan Elford, and others who really made a difference in who I became. This presentation is about a research study, but I hope it kind of introduces a broader type of thought in the process. A few necessary disclaimers. Views here are not those of a federal or state agency. They're my own. I don't have pharmaceutical stock or opioid litigation involvement. I own some stock in Thermo Fisher, which I think makes lab equipment, and I edit an up-to-date chapter. I've served as an expert in an administrative dispute between a doctor and an insurer, but I don't do legal work. And this is monitored by both the Veterans Administration and the university's Institutional Review Board. For today, I'm going to introduce the challenge we face with opioid prescription reduction in patients with pain and a history of long-term receipt of those medicines, with these correlated outcomes that we've seen of suicide and overdose that are hard to explain, and that what's missing is detailed, actionable knowledge on how we can address those. This briefing is on the VA-funded CSI opioid study. I'll talk about who we are, the data behind the study, the rationale for looking at individual suicides, and our methods. This is not a portrait of all the people who came together to do this study, but I think that understanding the kinds of people who come together to take an interest in this topic actually is really instructive for why this is a tough question to address, because of the people whose collaboration you have to need and it put together, and we don't always work together. On the left-hand side, you would see research and clinical expertise, including Dr. Gordon, Allison Varley, Megan McCullough, myself. Our study coordinator is actually in the lower right, but studies that are focused on the experience of vulnerable populations, people with lived experience, are really crucial. And that includes Anne Fuqua, who I'll talk about in a moment, a person who herself has long-term pain, families who have lost someone to suicide in the wake of prescription opioid reduction, including both Cassania Richardson Sloan and Jim Elliott, whose brother was featured in a story on Vice.com last year, Don Gibson, a disability advocate. There are people who are in the pain advocacy space who work with the federal government in an advisory capacity, like Kate Nicholson and Kristen Beasley from the NIH HEAL Multidisciplinary Work Group and her own nonprofit, and then suicide experts. And these are not all of them, by the way, but two of the most prominent are Thomas Joyner from Florida State University, who's the author of Why People Die by Suicide and source of a key theory behind that, and Stephanie Campbell, who leads the VA's behavioral health autopsy team. The correlational data has what led us to trying to do this study. There are three studies I'll touch on very briefly, but these are concerns that have been mentioned in the media and seem to be substantiated in big database retrospective studies. There was an association in retrospective data between discontinuation of opioids and suicide and overdose death in a VA report published in 2018, but based on earlier data. This particular study was, I was a co-author. It controlled for more clinical covariates than most other studies, but lacked insight into why or how opioids are stopped, whether that was wanted or not, whether it was slow or fast. And it's somewhat older data. A more recent Oregon Medicaid study. Oregon has been a leader in creating regulations and restrictions that would typically induce clinicians to reduce their prescriptions. But a study from Oregon Medicaid found that suicide events, both fatal and non-fatal, were statistically correlated with stoppage. Actually, that rate of those events was higher if there was an initial dose reduction before the stoppage, which only seems kind of surprising. And can people just confirm for me that the mode that you're seeing is the full slide?
Yeah.
Good.
Yes.
And then that's a concern, but it's a small study. Finally, within commercial Medicare data, there have been a couple of papers published that showed mental health crises were elevated after dose declines, and that the rate of these crises was elevated out to 24 months from the date of the change. But why or how those reductions occurred is unclear. So with these data, coupled with some anecdotes from the public, federal agencies have spoken. What have they said? Well, the FDA said in 2019, avoid rapid or abrupt taper. The CDC in 2022 said, avoid rapid or abrupt taper, consider the benefits and risks before making a decision to dose reduce, and consider shared decision-making. The VA's internal risk mitigation system, which is a clinical decision tool called STORM, actually has a little warning when you open it up that says the discontinuation may not make your patient safer. Those are perhaps important things to say, but they really don't say very much about suicide itself. The reason for that is the weakness of the data. Slower reductions avert acute withdrawal from opioids. We know this from care of people with dependence of any kind. However, this is not very much to do with suicide. In reports to date, slower reductions generally do not substantially reduce the risk of overdose or suicide, although those are just correlational data. But the key is, to date, we could not argue from available data that slower reductions prevent this particular outcome. And suicide is really not the ordinary result of acute withdrawal from opioid medication or even fentanyl. So we need to think about suicide in a more serious way if prevention is our goal. And we have to start with the most basic and fundamental of questions. What happened? And why? These are the questions we need to ask. The common analytic approach to difficult events that I've described to you is a classic big database approach. And imagine if we were to apply it to something like airplane crashes. So if you were to study airplane crashes this way, you would take a database of all the airplanes in the world that went up, then you would find a few that went down, and then someone would plow databases to see if from standard data elements, such as pilot age or the weather, they could predict what kind of airplane or what kind of situation would cause a crash. And then they would make some odds ratios, and there might be real understandings that might arrive from that. I will come back to the airplane example, but I think in a way, this isn't an ideal way to think about suicide. The model for suicide that normally is used in the literature, the model for suicide that is normally, well, at least one of the most common ones, considers suicide as a complex event that's influenced by multiple layers of influence, starting in society. These are things that you can assess, obviously, through interviews or records review, healthcare policies, firearm policies, stigma about seeking care for mental health conditions, community factors like where people live, the types of resources that are available to them, organizational factors like the messages sent within a healthcare setting or insurance status, or organizational policies around opioids. Interpersonal things like relationships between the individual who might die by suicide and the people around them. That could include healthcare providers. It could include their level of support from social media or from friends or from their healthcare providers. And then finally, very individual factors such as the person's level of pain, their history of medication receipt, whether they have dependence. There's a concept called psychache, which is sort of the total psychological pain that they are in, regardless of how you attribute it. And all of these are likely to have some bearing on the decision that a person might make to die. We came to think that these might be approachable by getting case histories from a unique individual, Ms. Anne Fuqua, who I believe is attending this call. Anne is actually an assistant to our study, but she's also a patient with long-term pain who lives here in Birmingham, Alabama. And for years, she had been privately tracking deaths by suicide, as well as other medical events that were reported on social media in the many communities she participates in, and tracking them for herself, not for our research, as concerning issues that were not being discussed very heavily elsewhere. And we ultimately, some of her work was profiled by Maya Salovitz, the New York Times, at the beginning of this year, and she had hundreds of cases in which people mentioned suicide. And to Anne's credit, she tried to adjudicate how many of these were likely to be credible. So in this staged photo, it looks a little bit like the Last Supper. Anne is sort of instructing our research team to take this on. And that's what we wanted to do, but we can't just grab Anne's data, as you'll see. That's not really ethical. So the aims of our study, as funded by the VA, although it includes non-veterans, are to characterize patient and context factors associated with suicide among 110 to 115 persons who died by suicide in the context of a prescription opioid reduction. Doesn't mean caused by, it means occurred in the context of. And then to identify those factors that might differ between veterans versus non-veteran suicides. And just to return to that model of studying an airplane crash. I give this example of the TWA Flight 800, which crashed roughly when I was beginning my job at Boston Healthcare for the Homeless Program. There was a lot of rumor about why this crash occurred, and there was not a statistical model used to study and make sense of this crash and prevent the next one. Rather, the case was investigated closely, and it was found that there was an explosion due to ignition of a flammable fuel air mixture in a hot and mostly empty center wing tank. And rules were changed to prevent that from occurring again. And there is an analogy in the realm of suicide research, and it's called psychological autopsy. This kind of work has been around since 1963. In the most typical instance, investigators work with a state or local medical examiner and pull all suicides or all overdoses and review those cases all as they come. For certain reasons I'll explain, we cannot do the same thing. But this kind of method has a certifying body, which it could be trained in, which is the American Association for Suicidology. Our team was trained. And actually, as a test case, because it was public information, they asked us to try to develop a psychological autopsy profile of a well-known suicide, specifically that of Kurt Cobain, which I'll just sort of summarize a few of the factors that come to mind. And you'll see both how unfortunate the situation of Kurt Cobain is, but also how unique the factors are that emerge when you look closely at an individual case. I showed a picture of Kurt with not as a rock star, but as a dad, because I felt that this loss was also the loss of a father. In his family, there had been suicide attempt or completion in 4 distinct relatives a generation before him. That's a pretty big risk flag by itself. His early life was characterized by parental separation and a lot of conflict between himself and the other parts of the family after the separation. He also had severe chronic abdominal pain, which to our knowledge has not been ever diagnosed. In the late 80s, he used heroin sometimes, and he referred to it as recreational use. And in his own writing, he said that he began to use it more regularly for care of his own pain condition, which was not diagnosed. And he described the pain as severe enough as making him want to kill himself. And this is when his career is really taking off. Amazingly enough, in 1992 to 93, he was briefly, for different periods from different doctors, on methadone and buprenorphine, 2 evidence-based treatments for opioid use disorder. And then in March, he actually had an overdose, not with opioids, but with alcohol and Rohypnol. There was an actual confrontational intervention by members of his family and friends. He was sent to a Los Angeles-based detox. He did not receive evidence-based therapy in 1994 for an opioid problem. He climbed over the back fence, went back to Seattle, and having had his guns taken away once, he managed to reprocure a gun and ammunition and died by a gunshot. And those themes all have potential clinical and policy lessons from a single case. Now, just imagine what would happen if you looked at 110 or 115 cases, as the VA has funded us to do. There are questions we can approach through interview and medical records that are different from those you can ask from a statistical database. How many decedents had rapid or slow opioid taper? That you might get out of a database. Was there a hint of potential for self-harm before or after? Some of those hints aren't even going to be recorded by busy primary care doctors and records. You have to talk to people. How many people who died described a concern to others? Were there risk factors from the interpersonal theory literature, perceived burdensomeness to others, or a thwarted sense of belongingness? What healthcare contacts took place before the suicide? Did healthcare feature conflicts or impasses in care? Was there possession of medication or a firearm? For veterans, how many went outside the Veterans Administration or went to an emergency department? Those are just some of the questions that could be approached, provided you can find the families. And that leads me to discuss our recruitment, which is mighty challenging. The simplified overview of the CSI opioid study, and it is in a beginning phase now, is that there's outreach primarily to the public. There's a screener survey, which has been up and ongoing, and I'll show you where to find it by the end of this talk. People who pass the relatively detailed screener, they have to consent to get into it, both online or by phone, but then there's a more detailed consent that's sent out by our team, either by mail or electronically. And if they consent, we do a detailed survey/interview with that individual, as well as an effort in medical record solicitation if they have that authority, or if they know somebody who has it, we reach out to that person if they think that that's appropriate to try. And then we are going to develop a synthesis of the story of each of these deaths. The real challenge, the fundamental challenge, and the reason no one else is trying to do this is that the recruitment is tied to suicides, which any medical examiner can find, but it relates to a pre-mortem or a care change before death. This is the challenge, because medical examiners and coroners, the ordinary partner, normally lack information about healthcare changes before death. We are still reaching out state by state, organization by organization, in case some do have it. Another approach some people might suggest is, hey, why don't you beam into the medical record system of a large healthcare system, maybe the VA or others, and find out where the suicides are, and then try to approach the families. But there are serious regulatory problems with reaching out in that way from medical records. There's also a liability risk for the organization that might feel that if they are implicated in some way and possibly being seen as having contributed to a death, they may fear liability for the basis of such a study. And finally, the families that you reach out to, if you say, hey, I'm reaching out on behalf of a healthcare system, they may feel like they're being chased after. It's kind of creepy. And they may also feel hostile to the healthcare system. So this is not the easiest approach either, although we're exploring it. So really what we chose, and what makes this somewhat unique, is a direct to the public approach, which involves both media and partnering with organizations and individuals, and presentations like this one. This has not been tried, to our knowledge, in prior psychological autopsy research. It does require money and marketing. It requires the trust of a community that's itself traumatized and somewhat upset about what's happened in healthcare. And it requires credible partners. And we believe this is likely to be the only way to take a look at these deaths. And we've been piloting this since late 2020. I'll show you first a graphic that we prepared and used for the first year and a half, and sometimes still put up. This was our own hand-created social media. It's in the colors of our university, because we were trying to recruit both veterans and non-veterans. It says research at the top. There's no mention of a prescription directly, unless you read into the name of the title, opioids. There's no simple cause-effect relationship implied between the prescription change and the death. We had stock images of various ethnicities and races, but We also learned some lessons when we spoke to professionals in the media relations world. If you were to pay to put this on Facebook, two words would be probably prohibited. One is you. Have you is a definite sign that somebody's being profiled and it's creepy. So we couldn't actually deliver this in a paid Facebook ad. Similarly, suicide may be enough to be banned as an advertisement. So new approaches will be required with a paid media campaign. Nonetheless, we put this out there on our own social media as individuals, and a meaningful number of people responded. I think close to 1,000 touched our online survey. I'll come back to that. And that online survey leads us to adjudicate who might actually be a credible participant. There's a 46 item screener hosted on a secure RedCap server at the University of Alabama, Birmingham. And we have to go through a set of questions, but two are crucial. One is the age and whether the person wants to be contacted again, of course, but then we ask, how confident is the reporter, who may be family or close friend, how confident are they that there was a prescription opioid reduction or stoppage? And in that item, they're allowed to say that they're unsure or that there were multiple changes, and they're allowed to put in a lot of free text. And the second one is, how confident are they that the death was an intentional act of suicide? Again, there's a level of confidence and plenty of free text. And we manually adjudicate every pair of responses to identify who we can reach out to. And each one of these 46 items in the survey was reviewed both by patients, by consultants, by suicide experts to make sure that the questions are sensitively asked. A key question that Miriam raised when I was preparing this talk is, how about our efforts to deal with non-white, minority, and diverse populations other than standard white folks? Well, I think just as a matter of background, it's important to acknowledge that the literature has shown that over time, prescription opioids were offered less to Black people. Indeed, I helped publish one of the first major papers with national data on that, and that in some research, tapering is initiated more often in Black people. And in some literature, urine drug testing is administered more often with no clear medical or physiological justification for any of that. Our pilot recruitment percentages are shown 8% Black. That's less than the percentage of African Americans of the US population. 6% Native American and Alaskan Native, 14% Hispanic Latino. Now, our images and our team are diverse, but further efforts to reach Black families are definitely required. So let me, and then by the way, just so you can see on the right, there's a draft media image for a campaign that has not started. Just so people know, there are some people on another Zoom link, apparently. I just got a message about that, wondering if anybody can notify those folks, but I will just ask if there's any way to send out an announcement to let folks know they are interested. But I'll just continue here. So we decided that maybe the first thought about reaching Black populations was to consider that there is one African-American population, or mostly African-American population, with a lot of pain, and that is the sickle cell disease population. We reached out to a local sickle cell disease expert to ask for possible assistance in touching on national organizations that deal with the sickle cell population. And they gave us a kind of familiar hesitation in response, which I think is really instructive, which is that they understood the reason for the study. And then I'm paraphrasing, they said, but if I share this study, my colleagues will think that and what would they think? Well, this particular expert is concerned, knows unsurprisingly, that prescription opioids were given too strong a vote of confidence in the care of sickle cell disease. This particular expert has knowledge about opioid tapering and fears that sharing information about the study would be seen as undercutting a separate concern that they're trying to raise about the overuse of opioids as they understand it. I'm not a sickle cell expert, but in sickle cell disease. And this has really echoed some incorrect inferences, but understandable human inferences we've heard before. Some people have said, hey, isn't this study just trying to prove a single cause and effect, that all opioid tapering causes suicide? Or perhaps that addressing the suicides could stand in the way of correcting a, a very high problem of excessive prescribing. And even sometimes people have argued this is so serious that maybe public agencies shouldn't support the work. Now, we always affirm the following, and I think this is the crucial response. We view teen suicide as a complex, multi-determined event. It merits examination so we can prevent it. And clearly, we do not think that the literature would suggest a single cause and single effect for an event like suicide. It's also really important to separate research from clinical care decisions or research from policy decisions. Those sit at a remove from each other, and that's the kind of reassurance we offered. But they still were nervous, and I think that's important to acknowledge. The other question that arose as we reached out to the public are some other issues. What about the families and the patients who are themselves scared or traumatized because there is an involuntary or sudden reduction occurring for them? Maybe their doctor retired and no one else will take them on. This happens. So our team can't provide direct clinical care, but we knew we would hear from people in crisis. We prepared a separate, rather long article, which you're welcome to check up on medium.com, about how families and patients can approach that potential crisis. It's just my thoughts. It's not a study product, but it's a necessary complement. There was also questions about the confidentiality of anything we collect. Some patients and families are considering legal action. We have 2 certificates of confidentiality which protect this information from legal discovery. There also are, as I mentioned, social advertising rules. And in our upcoming campaign, not only were the advertisements avoid frontlining words like suicide, you, or opioid, all of those have to be carefully managed. The website that it points to has to be entirely different from our study website because that too is checked by Facebook. This is the new draft landing page for the web page that you would go to if you saw our ad when the media campaign starts. Have you lost someone with chronic pain? Right now, the consultants believe the word suicide may be permissible in small text, but the rest of this doesn't really focus on the kind of language or causal inferences that could cause trouble. And people who want to get involved can get involved, and they can even do a 7-item screening survey. This is not up yet. It's shortly to happen. To date, we've mostly proceeded from unpaid media and word of mouth. Over 1,000 visited our screener survey. 52 have truly qualified. 9 consented and have been interviewed. More are being scheduled today. But several of the people who originally engaged with our pilot recruitment mechanism were stale, and they had lost interest in us and in the study, particularly if they had answered in early 21. The paid media will start. When people are interviewed, the questions we ask are derived from that conceptual model that I showed earlier. But just to give you an example, there's kind of false close-ended questions that are designed to see if the person perks up. Do you think his or her suicide was related to a specific problem or event? And then they can expound on what that event might have been. Were there any changes in the care they received for pain in the 6 months to a year before death? Again, we don't really go head on prescription opioids because we don't want to miss all those other factors in the model. Some of the topics that you see on the right-hand side are in our guide for the interview, which was derived heavily from the VA's internal behavioral health autopsy guide. Just a taste, and we're almost done, but just a taste of some of the initial storylines. And I've changed a few details here, and these are minor excerpts from 2-hour interviews. But I wanted to give you a flavor of the diversity of the stories that come through. In one case, the decedent was a male in his 60s. We spoke to the spouse. The individual had complex regional pain syndrome. There had been reductions of dose in one state, and then they would move to another state where the doctor said, I am under requirements. My clinic will be shut down if the doses go above a certain level. There were many other clinical risk factors, which I didn't try to summarize, but the interviewee does believe that the final straw was that this medication was taken, and that was a key figure. Another case, a brother. The individual had chronic pain from back injury and cancer. They had been previous overdose attempts. The doctors were hesitant to prescribe opioids. As you know, literature led by people here at Boston Medical Center shows that there's actually a fairly high rate of opioid prescribing after overdoses occur. Perhaps those are incautious. The interview believed that his brother was caught in a crisis and treated, quote, like an addict instead of a pain patient. Here's a different one, a very different flavor. A male in his 40s. We spoke with the cousin. We're working on getting the mother. Chronic pain from a car accident. There actually had been a suicide attempt prior to being on opioids. Then, this is a quote. He was pretty straightforward with saying, yeah, I'm addicted, but it was because he needed it. No one else believed him other than his mother. It's not that he didn't have pain, but no one needed to be that wasted all of the time. Then the suicide occurred at a holiday family gathering. That's a very different story. I'm not offering these to you to suggest that we have the deep analysis of each of these cases, but just to show you that you get diverse and real stories from human beings when you ask. Some themes from our interviews so far. This is from the first 6, although we're up to 9 now. We often heard about multiple pain doctors, multiple procedures, many kinds of prescriptions, previous suicide attempts, mention of suicide in conversations prior to death, an active lifestyle and outgoing personalities prior to the reductions, childhood trauma, family history of mental illness, ER visits, geographic moves with fragmentation of healthcare, financial stress, concerns from the reporter about addiction versus dependence in the care of pain, close relationships with family, but also a perception that the person who died was a burden to others. Let me conclude here. Where are we at? The reason this matters is that there are 5 to 8 million people on long-term opioids. Suicides and those overdoses that occur after prescription reductions are a healthcare-related event, but they're not well understood. And we can't just wag our fingers and say, don't stop opioids or taper slowly, because that's not rooted in knowledge. Health system interventions can be proposed if we learn more. But to do that, we're going to have to earn the trust of people dealing with these specific losses under a very unique set of clinical circumstances, and where public commitments to their safety and the people like them have been tentative so far. If you are interested in this, we are just about to launch our media campaign. I certainly ask you to share word of this. We are glad to speak with other audiences. You can always Google CSI.
Great. Thank you so much, Dr. Cortez. That was fascinating. You're obviously touching on a really complex set of issues, really delicate to explore, and clearly really important to explore. So much loss and grief and pain associated with this set of issues. I'm sure folks in the audience have questions and comments. Why don't we just open it up? Please raise your Zoom hand if you'd like to speak. Go ahead, Mark.
Hey, Stefan, thank you so much. It's good to see this moving. I know you've been working toward this for a long time. I want to give you the opportunity to talk more. So you shared the preliminary information on the 6 patients you've seen, and I'm just going to push on you a little bit, because so far what I see there is that you recruited a sample of people who had a suicide event after a dose tapering, and what you reported so far is that they had a suicide event after a dose tapering. And so there was a lot of information you talked about, more in-depth information that may be able to be gleaned from this autopsy, the psychological autopsy. And I'm curious about if you have any inkling into where that's going and what those lessons are, right? That you may be seeing and I don't know if it's just too small a sample size to share what you've seen so far, but
so, I mean, a couple things so to be very fair here, the in-depth analysis of 2-hour transcripts hasn't happened yet. We're actually still working through an IT issue to make sure that those transcripts can be sent outside the VA and then returned to us securely. Sorry, I just hit the mic. But I think the couple things that really do stand out are, one, that families are without a language to discuss the issue that they're watching in their loved one. And so they're frustratedly navigating with a sense of confusion. So if you're seeing someone suffer and you yourself have no language for the thing you're seeing, it is extremely difficult to help that person that you wish to help get help. The second thing is, it appears that the clinical system at times also has no language for the problem they're dealing with. They don't have a notion of what would, it's not just what would be good care, but how to describe the instability that they're seeing. And so that makes it hard to approach the problem as well. I think in that quote about somebody describing an individual who seemed to be, quote, wasted all the time, you can sense a real frustration that there's somebody who cares, is seeing something that troubles them, and they just don't know how to approach it, and neither does the patient. So some of this is about knowledge. The other thing that I think is pretty important is that idea of an impasse in healthcare. In a few of these cases, but not all of them, but in a few of them, the impasse is when there's a sudden disruption in care and the person either moves, or in one case, which I didn't put up there, there's a legal investigation and the doctor is shut down. And the impasse is either, where do I go next? Or if I go anywhere, the people who might receive me won't understand me. In fact, they'll view me with distrust. So I think that healthcare systems clearly could decide that they wish to designate the problems that they wish to prevent, that they want to talk about what those are and propose to prevent them, and provide a language to their own clinicians or their case managers about what those problems are. Health systems could potentially invest in systems to recognize and respond. Families could be provided with that language. To the CDC's credit, and this is a bit controversial at the moment because it may not have the reach it needs, but there is a program in the CDC that ostensibly should be helpful when the impasse is the result of a federal legal investigation. That's called the Opioid Rapid Response Program. And we have briefed that team in particular. I think they're just still kind of responding to some of these cases, and they don't always have a healthcare system ready to receive the patients that they identify as in crisis. So those are some, and none of these take away from the powerful challenges of perceiving oneself to be a burden to others, or feeling that you no longer belong to any group because of the changes in your life or the dependence itself or the loss of the medicine. Those are still strong interpersonal factors that can be responded to. Those are kind of preliminary digestions of preliminary data from 6 cases. Our goal is 115 and systematic collation with medical records. So the story may change after another year or two. So the most important assistance we need is to get the word out, because we don't know, essentially until the paid campaign is one piece. That's a contract that's been executed and about to start. The unpaid stuff began with social media. We're giving presentations, but if you are familiar with groups of patients or groups of clinicians who would like to hear about this, we're always available.
Oh, I am.
To speak. I'm always available to speak, as are other members of my team. And we also have handouts. We can put things ready for listservs. We're actually sending things out to listservs of coroners and medical examiners based on the advice of Dr. Gordon, actually, on this call. So if you know a listserv, let us know. You have a forum, let me know. We have every kind of material, including recordings of presentations. So Beth, thank you so much. Medical trauma is a very strong element, and to the extent that I've participated in both individual clinical care situations in my own hospital and participated in a public discussion of this with patients and families, the trauma we're talking about very often involves patients who are having big changes to care, which could be traumatic in themselves, but also patients who are being told that the concerns that they are registering are not reasonable concerns, that the concerns that they're registering about their safety are misperceptions of what will actually be good for them, that the concerns that they're having about their future survival are actually mistaken. This could be called, in some settings, gaslighting. That is, on face, if an adult tells you, I am deeply worried for my safety, my a priori assumption is I better take that seriously. But sometimes this is a domain where occasionally people don't recognize that there's a way to take something seriously and to validate that concern without assuming that the clinical decision that you're going to make next is already foreordained. I do think that many clinicians have responded to patients expressing fear or trauma in response to opioid reduction with the fear that if they validate the concern, the clinical decision they make is foreordained. That need not be the case. The issue is to respond like an adult, but we do have a number of things that drive healthcare trauma in our healthcare environment. Now, one of them is stigma. I think there's a great article, maybe co-authored by people on this call, called "I Felt Like I Had a Scarlet Letter: The Experiences of Patients Undergoing Opioid Tapering." That's a straight kind of description of subjective stigma. But I also want to highlight that individual clinicians, particularly physicians, are not cultured to we're not raised into medicine in a way that responds to patients consistently as adults who have perceptions that are very good, even if they don't have our medical training. And very often we don't engage with patients in part because we're afraid of being overwhelmed. We don't think we can manage our own boundaries. It's funny you mentioned borderline personality, right? That's often seen as a boundary issue for the patient. But the person who needs to be secure in their boundaries is actually the clinician. And we do have some challenges there. Obviously, I don't have a research language to describe boundary management, but for people who are interested in reflections on that, I have a colleague named Saul Weiner who writes a lot about it in a book called On Becoming a Healer. We even have a podcast of that nature that talks a lot about boundaries, the situations that might be termed gaslighting. I do think we're in a very traumatized environment, and I think we could do better as a profession, even if there was nothing to do with opioids and pain or suicide, just in all encounters. Next question, I think, might be Cindy's.
Right.
Hi, Dr. Gattiz. Thank you so much for your presentation. This is Cindy Steinberg with the U.S. Pain Foundation, and I've been in this area a lot and followed your work and appreciate you looking into this. We get people calling us all the time, as sadly as that is, with heartbreaking stories of their loved ones or they themselves who have been terminated from opioids. And I will give you an example of a woman that called me yesterday who was afraid her son is going to commit suicide. And to the previous caller's statement, anyone who lives with chronic pain, high impact chronic pain in America, is a victim of medical trauma, because these people are living with relentless pain 24/7, often have anxiety and depression, lose every aspect of their lives. They cannot sleep, they cannot work. They're financially, I mean, it's probably not that different from the life of an addict, because there's a lot of similarities, even though I think they're two distinct populations. But anyway, my question was, and you may have answered it with your previous answer, but, what do I answer these people? Because we offer support. I tell them about the programs that we offer for free for patients. But really what they're looking for is a doctor who's going to prescribe for them. And there are no longer any pain doctors or pain clinics. Truly find me one. No one will prescribe opioids to chronic pain patients, unless perhaps if they have cancer, but I even get calls from Dana-Farber doctors telling me they cannot fill their scripts. No doctor will prescribe, period. So I was hoping that maybe your studies so far have given you an inkling about prevention. I mean, at the end of the day, the reason to study this is to prevent more suicides. And when we get calls this complex with medical trauma, and I'm telling you, everyone has the same story, 15 years, going from doctor to doctor, treated like a drug seeker. Her son was a drummer and a 37-year-old. Talk about stigma, and he'll never get an opioid. So what do you think can be done to prevent them, even though you're not that far along in your study? And I'll just say one more thing. I'm sorry for going on because this is so relevant, but your last comment is so important that I think is overlooked, and that is empathy of the provider. Even if the provider is not going to offer them opioids, but will work with them, The thing I think that can help a lot is empathy of the provider, and it does not exist in the pain world now. So my question is, any other inklings besides empathy of the provider? Do you agree about that? And is there any other things that would help us tell people what to do when they think their relative is going to commit suicide?
So I have to draw a line between three things. One is the study's knowledge product is going to be a while. The knowledge product can lead to healthcare system information, and we intend to provide it as rapidly as possible. And my guess is that that does not, in the short term, address the crises that you are hearing about daily, which I've been hearing about as well as a human being on the front lines. So in order to approach your question, I have to set aside the study for a moment as a separate endeavor and just say, where are we at as a human being? And on that front, it's been frustrating for me when I hear from individual patients. I usually reach out to other patients who might be networked or who might know where to go. I reach out to professionals who might know where to go. I sometimes reach out to people at the AMA who may have lists and knowledge, but it's all very informal without a referral network. Separately, I took probably several hours drafting my own rudimentary guide for families in crisis. No one's tested whether my guide is actually the right one. And frankly, if you read it and you found something wrong with it, I would make changes to it. So I'll put a link into the chat. But it's the best I could do in a situation where the opportunities to identify care aren't crystal clear. I should say that sometimes, despite the fact that we don't identify long-term pain with opioid dependence as being an interchangeable condition with opioid use disorder, there is a meaningful contingent of people who are addiction trained who are open or savvy about the complexities of these overlap issues and are open to receiving some of those patients. That is hardly a definitive answer to the size of the problem you just scaled. The size of the problem you pitched requires a systems level answer with real commitments from large healthcare organizations that have to come from the top. I've seen indications of that in some healthcare systems, but not all. And then in the meantime, people are sort of scrambling. If you think the guidance I offer on how to scramble and how to approach this could be improved, I've put it in the chat. Let me know and I'll improve it.
Thank you very much.
The next, I think, I got a little forgetful in the middle of this, but it was probably Stephen.
It's Alex. Oh, this is like a hot potato. Okay. And I pass it to. So anyway, thanks for being here. I really enjoyed our conversation. And Marissa, it was great to meet you in person finally after many years of Twitter interaction. This is I have a lot I could say and thoughts on this subject. I guess one place, and sorry if you had discussed this, I had to step out for like 1 second of your talk, but I almost feel like there's a parallel here study around patients who die from chronic pain patients who die from overdose after being tapered, who go to the illicit supply. And I like to give the example of the woman in her 80s who I responded to an overdose on, who had been on opioid medication for like 30 years and came off. Grandson got her fentanyl. She used fentanyl for like 6 months and then had a street fentanyl and had an overdose. So I sort of wonder if like your recruitment efforts are finding some of those stories too. And if there's like sort of room to have like a parallel track. So I guess that's sort of one thought.
So from your lips to Nora Volkow's ears is what I would say to that. We do have some preliminary people who are reaching out to us saying, we have this other kind of death. Is your study for us? And we're saving the names. It clearly, the overhead to set up this machinery was large and heavy. Ms. Hogue, who's on the call, has been managing a boatload of complexity, but with more, unfortunately, I mean, with more resources, we can actually reach out and encompass another kind of traumatic event that follows a clinical change that results in death. And we hope to make that pitch. Honestly, I think it's pretty important. I think it's likely to be equally as common.
Thanks, Alex.
Last one, I think, might be Alex. Then we'll be booted off.
Hi, Stefan. It's so good to see you. And it's so cool to see what you're working on. This concept of psychological autopsy, I think, is really appealing. And there is a lot to learn from case findings and really doing a deep dive on individuals. The metaphor with the airplane really resonates. It makes me think about one study that we did as an EpiAid. So an EpiAid is a CDC supported outbreak investigation, which are traditionally reserved for infectious disease outbreaks. But in Massachusetts, we did one on fentanyl as an outbreak in southeastern Massachusetts. I'm going to put the MMWR link in the chat.
Thank you.
Self-promote, but we looked at medical examiner files of specifically fentanyl overdose deaths. And we did not talk to the families. We did not link to their medical records, which I think would be ways to improve upon what we did. But instead, what we did was we also did qualitative interviews on 60 witnesses of overdose and survivors of overdose. And we made those really the fentanyl overdoses was the idea. Because at that time, you're really trying to tease apart what the difference was with a fentanyl overdose from a other overdose. And that mixed methods approach, I think, was very instructive. And that's one of the things I got a little confused while you were talking. It seems when I go to the website, you're really focused on the decedents. And I'm wondering whether you have space in your study for the survivors. It seemed like some of the people you interviewed were actually survivors. And surviving a suicide versus dying from a suicide are two very different things, but they are related and they can help fill out the picture of what's going on. And so that's one thought I had as you were talking. One other thought is you are a cohort researcher. These are not cohort studies. They are case studies. But in certain cohorts, you have lots of prospectively gathered information among people who you don't know if they're going to die from suicide. And so are there cohorts that are more sophisticated or more detailed around the types of information that you want, other, outside of like medical record cohorts, right? Like a longitudinal cohort where you have enough people dying from suicide that could provide you information on what's going on. What are the characteristics of those people? Why are they dying? That's what you're really getting at, right? Is why these people dying from suicide after an opioid taper.
So a prospective cohort that exists would be good. There is one that kind of just came to mind to me while you were speaking, which is within the Veterans Administration and probably funded by my same funder, led by Dr. Aaron Krebs. And so that actually seems like a very interesting question we could ask, because the cohort has been in existence for a while. The goal is to get people, it sounds like, who may have survived, maybe not necessarily died, or potentially speak with people who've lost somebody from within an existing cohort, potentially where there are people who've already consented to be within the study. That's the key, is that rating medical records and reaching out to people after a tragedy of this scale is not the same as going to medical records and saying, hey, we have a hepatitis C therapy to try. So that's a great idea, Alex. I'm very thankful for it. And I think it does merit for us a follow-up call. I'll mention a couple of quick comments that have come through. There's a thank you, a notice to be aware of the March in 2024 conference for the Boston Addiction Conference. Might want to come myself. There's also a statement from Vision 20, which is one of our VA regional networks, and how they have opened up their services to be open to all people with pain, and including buprenorphine sometimes for pain or opioid use disorder either. And both of those are great. I'm also thankful for Stephen Martin posting a link to an article that I have read previously, but I think is worth reading, on what was the 2016 guideline. Obviously, there is a new guideline, but still that's in the links as well. I'll ask if we should adjourn. Are we there?
That sounds right. Thank you so much, Dr. Cortez. This was fascinating, and obviously people were really engaged and interested. We really appreciate your presentation. And thank you everybody who's joined. It was great to have you all here.
Bye, everybody, and thank you. We're honored that you received us.
Bye-bye.
Bye-bye.